Good day, everybody. My name is Kyle Klarich from the Department of Cardiovascular Medicine, and I'm coming to you from Mayo Clinic in Rochester, Minnesota, from the Department of Cardiovascular Medicine and Cardiovascular Surgery with our CME podcast series, Interview with the Experts. Today, I will be joined by two experts, and the topic we would like to discuss is very important about questions that patients and physicians may want to ask surgeons about whether they should pursue robotic-assisted approaches to surgical treatment of valvular heart disease. We further want to clarify how robotic surgery works, and including the assisted and associated risks, benefits, and the misconceptions that might be out there. We plan to discuss and have you better understand the expected short and long-term outcome of robotic heart surgery. So today I have the great pleasure of being joined by Dr. Philip Rouse, the Associate Program Director for our Cardiovascular Surgery Residency Program at Mayo Clinic in Rochester. He's an Associate Professor of Surgery at Mayo Clinic College of Medicine, completing his undergraduate at Arizona State University in microbiology, and attended medical school at Ross University, completed both his general surgery and thoracic surgery residencies at Mayo Clinic in Rochester, Minnesota. He joined our Mayo Clinic staff in 2018 after completion of his residencies. He has a great interest in robotic surgery, and that includes all forms of valvular repair. He also does valve replacement traditionally. He manages atrial fibrillation surgically, surgical management of hypertrophic cardiomyopathy, constrictive pericarditis, and arterial coronary revascularization. His interests include innovative valve techniques in particular, and also clinical outcomes research. Our other expert today is Marty Unruh, DNP, ANP, CNP. He has a lot of initials and is very important to our practice as he is a nurse practitioner and supervisor of the Department of Cardiovascular Surgeries in Mayo Clinic, Rochester. He joined Mayo Clinic in 2014 as an emergency room nurse, became a nurse practitioner in 2021, receiving his practitioner residency through Mayo Clinic School of Health Sciences, and he holds the rank of instructor in surgery. Welcome, Dr. Rouse and Marty. It's great to have you both here. Thank you.
Well, thank you, Kyle. Appreciate the opportunity to have this wonderful discussion on a topic that I'm very passionate about. Thank you for this opportunity.
Likewise, happy to be here.
Great to have you both. Well, let's just jump right in. I think what procedures you can perform robotically is probably something that's evolving, and we'd like to bring our audience up to date on that. So maybe Marty, you could start with that question, and then we'll ask
Sure
to jump in after that.
I'll give a stab at it. So some of the things that can be done robotically are ASD repairs, PFO closures, maze procedures. The bulk of what we do here at Mayo Clinic is mitral valve repairs. So we see a lot of those come through, tricuspid as well. Dr. Rouse, have you done any of the tumor removal through the robotic approach?
Yeah, so that's I would say the armamentarium that we have is really expanding. As Marty mentioned, mitral and tricuspid valve work is becoming really important to us. Taking out tumors of the heart, benign tumors most commonly are what we see. Papillary fibroblastomas are a common one on mitral leaflets, even on the aortic valve leaflets, we've taken them out on. And other benign tumors like myxomas, as they grow and start to either obstruct or become symptomatic or just are found incidentally, we're taking those tumors out robotically. And even coronary bypass surgery is an avenue that's being explored, and we've done a handful of those. So it's an exciting time to be a robotic heart surgeon and to push the envelope with this practice. But the armamentarium is exploding, and we're happy to be part of that.
There's a lot of great procedures that you can do with this technique, and I'll let Marty add another comment here because I could see he was anxious to say something.
Yeah. So this is also my time to interview Dr. Rouse, which is exciting for me. So, you know, while we get to take care of these patients post-operatively, but what I'm seeing is we can do single and double coronary artery bypass. Do you think that will ever evolve past that, Dr. Rouse, with
Yeah,
the robotic?
I think, you start with a single bypass to the LAD, arguably the most important graft to do. And then as the comfort level and the experience and expertise expand, then you can expand that practice to multi-vessel. But most of the robotic coronary work is really a blended practice with cardiology, hybrid type procedures with a combination of PCI, stenting of other lesions that can't easily be reached with the robot, and leaving the LAD, graftable by the robot.
It's great. It's so neat to see how things have expanded. And maybe you could mention what it takes to be a candidate for robotic surgery. I mean, can any patient have a robotic surgery, or are there certain people that are better suited?
That's a great question, Dr. Clarich. It's selfishly, I like to say we can use a robot on everybody, but there are some limitations to the robot, and it's important to talk about those things. So one of the limitations to the robot is it's not geared to be very effective in the extremes of body size, believe it or not. Really young children that have a narrower thoracic chest wall and chest cage, it's difficult to get the arms of the robot situated appropriately that you're not clashing with one another. And then the opposite is true. The other extreme on body weight, morbid obesity and whatnot makes it a bit more challenging for the arms of the robot to reach where you need to go. And so that's one thing we take into account. Sometimes there can be deformities to the chest wall. There can be levoscoliosis where the ribs tilt. They tilt to the right side, and that's typically where we do robotic surgery, is coming in from the right side of the chest. We have to go in between those rib spaces. And so if they're pinched off and real narrow, that does make some limitation. Another bony abnormality is a pectus deformity to the sternum, where the sternum kind of dips in and dips and depresses the heart. I would say that's not a contraindication, but it is something that we have to see on a CT scan, make some measurements, and see whether or not we can do that. And we certainly have been able to do robotic surgery in a handful of individuals with a pectus deformity. Concomitant procedures is something that we're becoming more adept with and publishing even on, mitral and tricuspid valve work at the same time. But if you needed a mitral valve repaired and you also needed a number of coronary arteries grafted, that's a procedure that we typically wouldn't do minimally invasively coming from the right side of the chest. We would do that through, a standard good old-fashioned sternotomy, which really is a good way. It really is a good way to do surgery in the right instance. When we do robotics and we come from the right side of the chest, there are periods of time, believe it or not, where we have to deflate the patient's right lung. And so this is before we're on a heart-lung machine. And so if the patient has extreme lung disease, COPD, emphysema, and we're concerned about how well they would oxygenate with the contralateral left lung while that right lung is down, we need to be thoughtful for that. So sometimes that might necessitate doing, pulmonary function testing before robotic surgery to see how healthy those lungs are. Would be another thing. So those are some of the things that initially come through my mind as to who could be a candidate for robotic surgery.
Well, I'm very interested in tumor removal, as a large part of my practice does revolve around tumors, and I've been really pleased to see that you're able to get them now off the aortic valve as well as the mitral tricuspid valves. Can you reach the pulmonary valve?
Pulmonary valve is just a little bit further away. The aorta sits in front of that when we're coming from the right side. To be honest with you, we have not done anything robotically on the pulmonary valve yet. And I guess I would emphasize the yet because the future is always, the bold and unknown. But right now we have not.
So if I could just summarize, it looks like maybe these are all relative contraindications and there could be some wiggle room around most of them, but extremes of BMI being either the very small patients, especially children, or very large BMI sizes with probably not an exact BMI cutoff, but I'm sure that there's worry about whether they're too big or not. And then scoliosis, pectus, and then COPD with some caveat that if they can, if it's not too severe COPD or emphysema, they might be able to be a robot candidate. It's interesting that you can do these combined procedures, and it sounds like a mitral tricuspid's pretty reasonable to do. And I wondered about whether you could exclude the left atrial appendage.
Oh, yeah. That's a great question. So, in oftentimes with mitral valve surgery, as mentioned, there's varying degrees of tricuspid regurgitation. And I would say at our institution, we're more aggressive with treatment of, up to moderate tricuspid regurgitation at the time of mitral valve surgery. We're gaining a lot more experience with that, a lot more comfort with that. Many of these patients will also have atrial fibrillation. And we are aggressive with doing cryo-maze procedure. And typically the way that we would address the appendage of the left atrium, when we come from the right side of the chest, the appendage is way over on in the left chest, and we can't usually see it as adequately, when we're in that chest space. So we tend to close the appendage from the inside with a little patch of supple pericardium, sometimes autologous pericardium, sometimes bovine pericardium, and we'll sew and patch up that the orifice of the appendage, and that's been a very good way in our experience with occlusion of that appendage at the time of surgery.
Dr. Rouse, there are a lot of talk about minimally invasive surgeries. Is robot the main way, or robotics the main way to do minimally invasive surgeries, or are there other techniques that we would use?
There are other techniques. So when we say minimally invasive heart surgery, we don't always mean robotic surgery. So there are procedures where you can still come from the right side of the chest and be in between those rib spaces, and the surgeon can perform the procedure, mitral valve repair, tricuspid valve repair, even aortic valve replacement, with long shafted instruments that the surgeon holds and puts through those little incisions through the right side of the chest. So that's a minimally invasive surgery. It still uses a narrow video scope and a screen to be able to see the anatomy clearly, but is not using the robot. There are other procedures, like a mini sternotomy, a little mini heavy sternotomy up at the top, where you just divide the upper maybe 4 or 5 centimeters of the sternum to perform like an aortic valve replacement, for example. And technically, we would say that's a minimally invasive surgery. It's not a full sternotomy. And so those are some non-robotic minimally invasive surgeries. But I would say that, sort of the pinnacle of minimally invasive surgery is robotics, because that allows us to shrink those incisions on the right side of the chest way down, like 8 millimeters in size. And it really is, that is the peak. That is the peak of minimally invasive surgery, is to do it robotically and really, really narrow down those incisions and still have the aid of a video scope to see the anatomy clearly, really better than you can see it open.
Well, it's really fantastic that we have these options available to us, but maybe we need to try to articulate what the, really summarize what the value and the benefit of robotics is over a traditional sternotomy. Maybe, Marty, I'll start with you on this one.
Yeah, I can talk about it from the postoperative period and also from kind of the patient experience. The biggest one obviously is going into this surgery, you're concerned about blood loss. And with this approach, there's less blood loss. And that's largely due to the surgical precision that the robotic allows. There's also lower risk of infection. You don't have the big sternotomy incision, and less pain is frequently talked about in the literature. From my personal experience, it seems like they have a lot of pain immediate post-op, which we manage really well with, PCAs and aggressive pain medication. But as soon as those tubes come out, these patients have an incredible relief of their pain. And we realize, immediately when those tubes come out, these patients are almost ready to go home. It's just really impressive how the robotic approach is such a fast recovery. So that's obviously one of the biggest benefits of the robotic is a really quick recovery. They actually spend less time intubated because it's minimally invasive, less time in the hospital overall, and smaller scars. Although I've seen some creative scar tattoos that people do with the sternotomy, but these are a really nice approach for people that are especially younger, don't want that big scar across their chest. So those would be some of the benefits that I see from the patient and the post-operative perspective. I'll let Dr. Rouse talk about the surgical perspective.
Before we go there, can I just ask a follow-up question?
Yeah.
For our audience? You mentioned that we usually manage pain pretty well, both for sternotomy and for the robotic procedure, in my opinion. But then you mentioned that after the tubes come out, maybe you could just clarify for our audience what tubes we're talking about.
Yeah. So they're left with at least one pleural tube, and that's in that space, in that right side. And it's like Dr. Rouse talked about, it goes through that rib area. And so ribs, with all of the nerve pain and the nerve endings, seems like those can cause a lot of discomfort to them. And these are traditionally on individuals that have a BMI less than 32. And so they're a little bit skinnier people, maybe not as much subcutaneous tissue there to kind of pad the tube. And so once that tube comes out, it seems like that just is a big win for them, and they're up and walking and ready to go home. So that's probably why it's most painful, because it's going through that rib space.
And what's the time frame that tube comes out?
Most often it's post-op day 1. So
Wow.
we can get it out. Yeah, they spend a night in the ICU, and a lot of times we pull it the next day.
Bill, did you want to add anything to that?
Yeah, one thing I believe all that Marty said is true. I think a misconception out there might be, well, if I'm having minimally invasive surgery, robotic surgery with little tiny incisions, then it's going to be pain-free. And the answer is it just isn't pain-free. We have gotten a lot more effective with how we manage pain. And one of the things from a surgeon's perspective that we do, and we've done this more recently now, is nerve blocking each of those rib spaces at the time of surgery. And so with local anesthetic, we can find that rib space. We can usually see where the nerves are residing, and we can block those nerves. And we've seen that regional anesthesia, that local regional anesthesia, can be a huge blessing for pain control immediately post-op. And as Marty mentioned, we do try to get those tubes out early. Very frequently, it's that next day after surgery. And usually any residual discomfort that's there once we take the tubes out starts to go away pretty quickly. And many patients are leaving the hospital without painkillers. Some still need it, but many are not. And so, but it's important to know that small incision does not necessarily mean it's less pain, but it certainly is manageable.
Well, it certainly sounds like a great technique from that quick recovery and in the hospital and being able to get people up and around really quickly after surgery.
Exactly.
So it's attractive from the patient's point of view, from the recovery in the hospital. How about the short and long-term effects of a robotic approach to surgery? Is it as safe and effective as a traditional sternotomy?
Okay, great. Maybe I'll take a stab at that first. I think that's a really important question to ask. If I have my valve repaired robotically, my mitral valve and or tricuspid valve repaired robotically, am I going to get the same result as if I had a sternotomy? I don't want to compromise that. And the answer is it is the same. And the results are the same. What's unique about using the robot is that the operation that one gets to repair their valves does not change from having a sternotomy. We do the exact procedure, the exact same techniques that we would use if we did a sternotomy, only we're using the platform of the robot and coming from the right side of the chest. And we've evaluated these patients. In fact, we've followed them echocardiographically over 10 years. And what we have found is the repairability of valve and the durability of mitral valve repair 10 years out from surgery mirrors our open practice. And so is it effective? Absolutely. Is it safe? yes, we would expect a risk complication rate of about 1%. And that mirrors the open approach as well, risk factor of about 1%. So it's safe, it's effective, and particularly for the mitral valve, we've also studied, to take it one step further, what about complexity of the valve? Should that change the approach? If it's not just a posterior mitral leaflet problem, or if it is only just a posterior mitral leaflet problem, should you just approach that robotically? What about if it's bileaflet? Or what about if it's an anterior leaflet problem, which tends to be a bit more tricky? We can repair all of those valves robotically, no matter if it's on the complex side or on the simplistic side. And our data shows that it's as effective as our open data. And so the complexity of the valve does not carry a sway into taking us out of the robotic approach.
That's very reassuring, I think, to people that might be really wanting a great repair, but also, all of us would like to minimize our time in the hospital, our time in recovery, and the scars that we have. We don't want to have a lot of scars, most of us. So that's really very, very reassuring. I think, Marty, one thing I didn't clarify, and I'd like to just come back to, what do you think the average stay in the hospital is? We talked about taking the chest tube out, the pleural tube out within the first day, and that implied that we're getting out of the hospital quicker. And then what is the amount of time most people would see themselves going back to their normal lifestyle, maybe their job or whatever their normal lifestyle would be?
Sure. That's a great question. And so, I mentioned that they typically spend one night in the ICU. They come to the PCU. The next day, we pull that tube off and on that post-op day 1, technically. And so by post-op day 2 to 3, we are often dismissing these patients. I would say the average is post-op day 3. Whereas, a sternotomy approach is we attempt to get the patient dismissed by day 5. So it drastically reduces their time spent in the hospital. From a recovery standpoint, these patients are often driving within 2 weeks back to their normal life within 4. What we tell them at time of dismissal is give yourself 4 weeks. With the sternotomy approach, we say 6 weeks, but it typically is much earlier than what we tell them, but we want to set expectations real so that 4 to 6 weeks, 4 weeks being the robotic and the 6 weeks being the sternotomy approach. So we see a pretty great recovery within 2 weeks of the surgery.
Wow. Anything else that you'd like to add to that, Dr. Rouse?
Yeah, I think robotic surgery, it's good for patients cosmetically, as we've talked about. It's good for patients in terms of getting back to work. It's good for society, for patients to be getting back to their jobs and their normal life. And I've had patients even texting me a picture on the golf course within the week after surgery. I didn't want him doing that, but he did it anyways. And I can tell you his golf swing was probably not the same, but these patients are doing really quite well. Within 2 or 3 weeks, they're going to be healed up. And in terms of healing from a sternotomy, a standard surgery, oftentimes it's 6 weeks, but sometimes it's longer than that. Many times it can be, 2 months or 3 months, depending on how slow that bone is going to heal. And so, robotics is great from that standpoint, really.
Because you take the sternum out of the picture and then there's less bone that needs to heal because the ribs are still left intact.
That's right. There's exactly right. No bone breaking, just soft tissue that has to heal. And soft tissue usually heals pretty quickly.
Wow. How many robotic surgeries has Mayo Clinic performed?
Oh, that's a great question. So we started doing robotic surgery at Mayo in 2008. And over the last number of years, we do about 200 a year. And so we are well over 2,000 procedures at this point and in time. And, that includes robotic mitral and tricuspid, maze procedures, taking out tumors, closing, atrial septal defects, other small congenital defects in the septum, all the gamut. So, over 2,000 cases is where we're at.
Oh, that's a lot of cases. And it sounds like probably the savings would be on hospital stay But maybe I do know that we use two surgeons in the robotic procedure. And one of the questions that I've heard from patients is, about, well, it's probably a twofold question. The savings, and we have two surgeons in the surgery, and then how much is the robot doing, or are the surgeons actually performing the surgery? I mean,
Yeah.
it sounds like a silly question, but for people who haven't seen it, I don't think, the robot, a lot of times we think about robots doing it all by themselves.
Yeah, that's
Yeah.
that's a really good question. Oh, sorry, Marty, go ahead. Good take, Steph.
Well, no, actually, it's interesting to me because I actually got to watch Dr. Rouse perform one of these surgeries, and it's intriguing to me because as a clinician, I can see why they would think a robot's doing this job. And so, Dr. Rouse would be out of a job if we actually got the robot to do it completely. But the console is set to the side of the room, and the patient is in the middle of the room, and he is obviously operating with his hands still, but it's a robot that is performing those exact maneuvers on his behalf. And so I'll let him talk a little bit more, but it's a very interesting to think that at some point, maybe people will be taken out of this picture. I kind of doubt that.
Well, I mean, it's a fascinating question to ask because we have cars that drive themselves. I was in Scottsdale just recently, and there was what's called a Waymo. It's one of these cars that it's a taxi car that you just order on your phone and it drives you where you want to go. There's no driver to it. And so what about when we say robot, is the robot just doing its own thing? Can we just program it? And the answer is no, as Marty said. So the robotic surgery, the surgeon is performing the entire procedure. And just as Marty mentioned, the console is where the surgeon sits. And I like to think of it kind of like a cockpit, like if you're a pilot. And inside that cockpit, you have a center console and there's an area for you to put your fingers into. And the arms of the robot are, docked right at the patient's bedside. And this cockpit is off to the side. And when the surgeon manipulates the little arms of the robot with a little finger movements, the robot very precisely replicates what the surgeon is doing with their fingers on that console. And so I like to think of the robot really as an extension of our fingers, inside the patient's chest. Only we are sitting remote and sitting in a little cockpit and manipulating it with our fingers on a console system. So it's like almost like a high-tech video game. I mean, I might compare it to that, but certainly the surgeon is doing all of it.
Well, what I think I've heard is that robotic is safe and effective. There are some maybe soft clinical decisions that need to be made about body habitus, COPD, some of the other processes that we need to take into consideration, patient-specific ones particularly. But overall, it's a very robust procedure that gets the same exact outcomes that we would expect from a mid-sternotomy, and with a much quicker turnaround in terms of hospital stay and return to your normal lifestyle, which is fantastic. So I would like to congratulate both of you on what a great option this is for our patients. And at this point, I would turn it over to the two of you. Do you have any closing remarks or anything that we want to point out further besides the questions that we've already discussed?
I think that me being younger in my career at Mayo Clinic, I am excited for the future. As we see these robotic procedures become more and more frequent, we're able to serve more and more people. And that's exciting, especially with the amount of people that need help in this nation and world. Being on the receiving end of those people is an honor to care for them.
Thank you. That's a really good point that we hadn't really talked about, is the short resources that we have in the medical system right now, and that if we could shorten hospital stays, if we can get people back, it's going to help the demand on the hospital space.
Yeah, I agree with all that. It's, as I mentioned earlier, it's good for patients from a healing standpoint. It's good for society, for them to be getting back to their jobs, getting back to their lives, their routine. I suspect that robotic surgery, minimally invasive surgery will continue to expand. We've talked about lots of different things that we're doing with the robot presently, but what are we going to talk about in 5 years from now and in 10 years from now? What is possible? And so it's great for patients. It's great for surgeons. At an institution like ours, where we are focused also on education, there's no better way to teach the uprising generation how to repair a mitral valve, how to repair a tricuspid valve, than putting the robot adjacent to the patient and putting it on a big screen. We've got multiple big screens in the operating room, and we can teach the next generation how to repair these valves, and they can see it. Otherwise, without that, we have an open sternotomy and you're in the deep chest. It can be very difficult to see what is the surgeon doing to repair that valve. And so robotics is also good for the next generation, how to teach and train the next generation of surgeons.
On those very optimistic notes, I think I'll again thank you both for being here and answering these very important questions about robotic assisted surgical approaches to our patients' care, and thank our audience for their time and listening to our presentation. And we'll be back in the future with another Mayo Clinic Cardiovascular CME podcast series, and we'll look forward to talking to you then. Until then, be well, take care, and have a great day.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Gonda Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.